So I'm going to talk on trigeminal neurinomas, okay? And trigeminal neurinomas are real skull-based tumors, and they are wonderful tumors. They are benign tumors located right in the skull base. And we have a very philosophical approach to remove these tumors. Just let me get my internet sorted out a little bit. Just give me one. On today or no?
Yeah, we can see your screen, sir.
We can see your screen.
Okay, so this is carotid artery, this is trigeminal nerve, and this trigeminal nerve has been split. So we have to know the anatomy of the skull base, anatomy of the trigeminal nerve, Gasserian ganglion, carotid artery, skull base, and things like that to be able to remove these benign tumors beautifully. So trigeminal neurinomas are relatively rare. In neurinomas, they are second only to acoustic tumors. And quite rarely, they are associated with NF2, neurofibromatosis, as we know. In the year 2002, I had presented this article. 2002, I had presented 73 cases, which was the largest series at that time. And in the year 2017, I had analyzed my cases, and there were 260 cases in 2017. Now my series is beyond 300 without any doubt. So this is the largest series of trigeminal neurinomas. And this article of mine was, I will consider one of the most beautiful articles on the subject. In this article, it was mentioned for the first time in the literature as a series that you can operate on trigeminal neurinomas and you can improve the trigeminal function, the sensation of the face after surgery. So this was the first article. In this article, it was mentioned that the trigeminal neurinomas arise in the region of Gasserian ganglion in the Meckel's cave. So these were two very important things that were discussed in this article. And also in this article, it was mentioned for the first time in the literature, the dural relationships of trigeminal neurinomas. So this article I consider as very important article on the subject, and it has been cited nearly 300 times in the literature. So this is the slide provided by my resident and now my colleague, Dr. Sukhdeep Jhawar. So this is trigeminal nerve over the petrous apex. Here is the Gasserian ganglion, V1, V2, and V3 divisions of the trigeminal nerve. Trigeminal neurinoma, trigeminal nerve is located in the lateral wall of cavernous sinus. The V1 and V2 divisions and V3 division parts the company of cavernous sinus right in the beginning after the Gasserian ganglion emerges. So this is the third nerve, the fourth nerve, V1 division, V2 division, and V3 division is not in the lateral wall of the cavernous sinus. And this is the sixth cranial nerve, which is located right inside the cavernous sinus. In the middle fossa, the trigeminal neurinomas are of three types. One is when it is located primarily in the middle cranial fossa. So this is type A trigeminal neurinoma. We had described that these tumors are located entirely within the confines of the dura of the lateral wall of the cavernous sinus. So this tumor is located within the dura of the lateral wall of the cavernous sinus or is located interdural in location. So that is very important for the surgical issues, but because when we talk of interdural location, the cavernous sinus is lateral to the tumor and to the dura. Carotid artery is away and the dura separates the tumor from cavernous sinus and from carotid artery. So this location, interdural location, is a very critical location of these tumors. When the tumor is located entirely in the posterior cranial fossa, so this is another type of tumor. One is in the middle fossa and one is entirely within the posterior cranial fossa. More often, these tumors are dumbbell-shaped in the middle fossa and in the posterior cranial fossa, both these dumbbell-shaped tumors. So this is also a very common form of trigeminal neurinomas. So this dumbbell-shaped. We had described that this middle fossa part of the tumor is interdural in location. In that paper in 2003, we had suggested that the posterior fossa component of the tumor is intradural or subarachnoid in location like acoustic neurinomas. But now we have realized that on several occasions, even the posterior fossa part of the tumor is interdural in location. So essentially, the entire tumor is covered with dura. Middle fossa component and the posterior fossa component both are interdural or within the confines of the dura. So this is the middle fossa part of the tumor. This is the posterior fossa part of the tumor. This is also not always, but frequently located interdural. And tumors which are extracranial also, this is the fourth part. One is either only in the middle fossa, only in the posterior fossa, dumbbell-shaped, and the tumors which go in multiple compartments like extracranial tumors. When the tumor is extracranial in location, the posterior fossa component is almost certainly interdural in location. So this is maybe small middle fossa, large posterior fossa. These are extracranial extension. You see, this is extending along the V1 division of the trigeminal nerve.
Hello, Dr. Nisola.
Hello? John, you said something?
Hello.
So, yeah, you said something, John?
John, unmute.
Okay, so these tumors may extend along the V1 division of the trigeminal nerve, along the lacrimal division. This was the first time we described such a, yeah?
John, the link has expired.
No. Okay, there's a link.
Hello?
There's a link now. I'm sending you. I've sent you. It's not expired.
John, is there any problem in the...
You see the link I sent you?
Hello.
Yeah, I sent you a link.
Okay, okay. Right,
Okay, use that link, okay?
John? John, can you hear me?
Sir, please continue.
Achha, you are able to hear now, Nilesh?
Sir, yes, sir, we are hearing you.
Can hear you, Atul. Go ahead.
Okay, okay. Sorry. So these tumors can go along the lacrimal or the V1 division of the trigeminal nerve. So this was a rare kind of a, location that we described earlier. This tumor can go along the V2 division. You see along the foramen rotundum by the side of the teeth, this is V2 division of the trigeminal nerve. And this is a tumor along the V3 division of the trigeminal nerve along the foramen ovale. So the issue is, what we said is that these tumors arise in the region of Meckel's cave. They can go in the posterior fossa in a form of dumbbell shape or in the extracranial compartment. But whenever there is an extracranial compartment, there is always a middle fossa component always. The other thing that we mentioned is that even the extracranial compartment tumor is within the dural confines. So this is a very important surgical thing that we discussed, that extracranial part of the tumor is also interdural in location. So in my paper, this was the size distribution. As you can see, type A is only middle fossa, type B is only posterior fossa, type C is dumbbell shaped, and type D is when there is an extracranial compartment extension. So these are the percentages of these kind of tumors. Trigeminal neurinomas can be small and trigeminal neurinomas can be huge. More important is they have very characteristic presenting features. When there is predominance of numbness of the face and when there is predominance of the wasting of the temporalis and masseter muscles, these are more likely to be trigeminal neurinomas in this location. So they have very characteristic clinical features. They can be quite huge and necrotic in nature. You see this necrotic and huge, but this is a trigeminal neuronoma by the characteristic and classical presenting features. So they can be huge dumbbell-shaped tumors like this. So size-wise, you can see many of my tumors were quite big, more than 6 centimeters, 4 to 6 centimeters, and small tumors were relatively less frequent. The other very important features of trigeminal neuronoma is they can be cystic in nature. You see, this is a trigeminal neuronoma where the middle fossa component is bright and posterior fossa component is dark. So cyst of multiple intensities. So this is usually found in craniopharyngiomas, this kind of multiple intensities of tumor, but even trigeminal neuronomas can have this kind of intensities. The other thing is that trigeminal neuronoma, the cyst can have a fluid level. You see a fluid level within the cyst? And these kind of schwannomas can frequently have fluid levels. And this is another beautiful tumor where you can see multiple fluid levels. There is a fluid level here, there is a fluid level here, there is a fluid level in the middle fossa component. So this dumbbell-shaped tumor having multiple cysts with fluid levels, and all the cysts are having levels. And these are very classical of schwannomas. And this is another huge trigeminal schwannoma. And if you see it carefully, there are multiple cysts in the tumor, and all the cysts have fluid levels. You see this fluid level, fluid level, fluid level, fluid level, fluid level. So there are multiple fluid levels. Trigeminal neurinomas can be bilateral. You see bilateral trigeminal neurinomas, and this is more common in NF2 situation. Not more common, they are always associated with NF2. This is another fantastic trigeminal neuronoma in an NF2 patient. You see there is a huge acoustic tumor and there is a trigeminal schwannoma. and both are almost touching each other. So these are, unbelievable kind of tumors. And these kind of unbelievable things are usually seen in NF2 patients. So this is NF2. This is another NF2 patient in which you will see various cranial nerve schwannomas. Like this is seventh nerve schwannoma. There is a sixth nerve schwannoma, there is a fourth nerve schwannoma. There is also a sixth nerve schwannoma, and there is a fifth nerve schwannoma. So there are multiple schwannomas in an in a NF2 patient. This is another very extremely rare kind of situation where trigeminal neuronoma has ossification. You see, there is bone formation in the tumor. So ossification in a trigeminal neuronoma has never been reported, and we have reported in my series 6 cases of trigeminal neuronomas with ossification. This is another very interesting case of trigeminal schwannoma. This is trigeminal schwannoma associated with another tumor in the retroorbital region. And this tumor was a hemangiopericytoma, and this tumor was a schwannoma. So there are 2 tumors, and both are relatively, hemangiopericytoma is of course a malignant tumor. This patient was blind in this eye, and this eye, as you can see, is completely bulging out of the socket. And this was first removed, and then this was removed. You can see this is a vascular tumor, hemangiopericytoma. This tumor was removed first, retroorbital, and then this schwannoma was removed, and both the tumors are removed in this slide. And this patient now, after several years of surgery, is completely asymptomatic, no radiation, nothing. Eyeball was intact. And when I saw this patient, the patient was in plastic surgery, and they were about to remove the eyeball with the tumor. So we not only saved the patient eyeball, but also we saved his face. Of course, the vision he was still blind in this eye. More common, these tumors are in middle age, rarely in very young people, and very rarely in older age group. So middle age from 21 to 40 is the more predominant age group of these tumors. Diagnosis of these tumors is very essential to make preoperatively, because preoperatively you have to know that you are operating on a trigeminal neuronoma. So they have very characteristic clinical features, symptoms of trigeminal nerve involvement like numbness in the distribution of the fifth nerve, wasting of the temporalis and masseter muscles are very characteristic form of presentation in trigeminal neuronomas. We had identified pathological laughter in these kind of dumbbell-shaped tumors, and I had reported 4 cases, and now I am having at least 8 or 9 cases where the patient had pathological laughter. Like you see pathological laughter in hypothalamic hamartomas, but pathological laughter in trigeminal neuronomas can also be a very dominant presenting symptom. They have very characteristic anatomical relationship, and these are very important for us to understand if we have to decide and devise a surgical strategy. Trigeminal neuronomas are located, trigeminal nerve is located right in the petrous apex in the floor of middle fossa. It is covered by very thick layer of middle fossa dura. That is one thing. And second thing is, it is the entire trigeminal nerve, the Gasserian ganglion, has its own discrete dural membrane. So middle fossa has 2 dural membranes. One is middle fossa dura, and the second is dura of the trigeminal nerve. And the dura of the 3rd and 4th nerves are also discrete. So this discrete form of dural understanding is very important, because no matter how big the tumors become, they remain within the dural confines or within the dura. Surgery on trigeminal neurinoma, if you know, many of the people in the audience are obviously very young. Trigeminal neurinomas were not operated frequently about 30 years ago. They were not actually diagnosed properly before the MRI came into being. And even in the years 1980, 85, 89, 90, when skull-base surgery was actually born and came into being and existence, trigeminal neurinoma surgery developed and evolved, and ultimately, as you all know, it has thrived and it has become one of the most favorite surgeries for a skull-base surgeon. In the year 1992, we operated this case. At that time, all these trigeminal, these large and huge trigeminal neurinomas were very difficult to diagnose, and all these tumors were operated in 2 stages. Actually, 1-stage surgery was first introduced by Leonard Mallis early in 1980s. Then, of course, various skull-base surgeons came into picture, and 1-stage approach became the most preferred approach for these tumors. So this tumor I operated in the year 1992, about 28 or 29 years ago. And we removed first this middle fossa component, and then we removed this posterior fossa component, and this was removed in 1992. This was another tumor I removed in 1992. The strategy was the larger tumor was first removed, and then the smaller tumor was removed. See, this tumor, the middle fossa component of the tumor was removed in a 2nd stage, and this was removed, both were removed as a 2-stage surgery. But when the anatomy of this area developed, understanding of the skull-base surgery, understanding of the petrous apex evolved, these tumors were then removed in single stage, and our own contributions to the field of trigeminal neurinomas, I will say without hesitation, has contributed significantly in the development of surgery of trigeminal neurinomas. We said earlier that in the middle fossa component, you play with the dura. You remain with the inside the dura, play with the dura, and remove the tumor. Posterior fossa component, in the year 2003, we said that you play with the dura and play with the arachnoid because they are located in a subarachnoid location. So this was the initial picture. This is trigeminal nerve. You see, this is the Meckel's cave. There is a lake of CSF in the Meckel's cave. This is the Gasserian ganglion, V1, V2, V3. Majority of these tumors are many of these tumors are middle fossa tumors. They remain within the dura. Tumors, when they go in the posterior cranial fossa, they have discrete anatomical situation. So we understood the dural anatomy. We approached the middle fossa tumors extradurally. We approached the cavernous sinus tumor extradurally. And we approached the trigeminal neurinomas interdurally. And all these things were discussed in my book, which we presented in the year 1996. And many of the articles of mine in this book are focused on the subject of dura. And the dura is the mother of brain. In the year 1995, for trigeminal neurinomas, on the basis of the concept that these tumors are interdural or within the dural confines, we described an infratemporal fossa interdural approach. You see the hands of the surgeon, remove the zygomatic arch, widen the foramen ovale. So this tumor we removed without craniotomy, just opening the foramen ovale. In 1995, you can imagine we had a clear impression about that this tumor is within the dura, and we had a clear impression that this tumor was a trigeminal neurinoma. Only then we could have the guts 26 years ago to remove this tumor, which is in the cavernous sinus. And in that location at that time, 25 years ago, nobody was touching cavernous sinus tumors. Even today, not many people have enough information about cavernous sinus tumors. So in my book, in my paper in 1995, I gave this picture. So you see this tumor was removed without craniotomy. This was another tumor in my same paper. This tumor is going in the posterior cranial fossa and in the middle fossa. And this tumor we remove with this kind of craniotomy, just widening the foramen ovale without doing any temporal craniotomy. And we removed even the posterior fossa crane component by widening the foramen ovale. This was also in the book, in the same paper, where we removed this tumor by just doing widening of the foramen ovale. Essential is not the exposure, essential is the philosophical understanding that these tumors remain within the confines of the dura, and you can work within the dura to remove these tumors, and you can more importantly, you have to save the trigeminal nerve fibers to preserve and improve the function of the trigeminal nerve. So we also described similar theory for oculomotor neuronomas. We said that oculomotor neuronomas arise from oculomotor cistern in this location, and these tumors, as they grow, they take the dura with it, and interdural location of oculomotor neuronomas. So these tumors can be quite difficult to understand, but if you know that this tumor is an oculomotor nerve tumor, and they are located within the dural confines. Oh, just a minute, please. Work within the dura, and save the dura. This is not the tumor capsule. Don't try to remove this capsule. If you have this concept, you can preserve the third nerve function, even if there is some tumor residue. So this is a third nerve neurinoma with a clear dural margin. The concept is open the dura, work interdurally, and you don't try to remove the capsule, and you will be able possibly to save the third nerve function. Similarly, we describe for C2 neurinomas that they arise outside the confines of the spinal canal. They are not inside the spinal canal, they are behind the C1, C2 articulation. And the tumors which arise from the C2 arise from the ganglion, and they remain within the dura of the C2. So this C2 neurinomas, we described 60 cases in 2008, and more recently, I described 50 cases of C2 neurinomas. The concept was that C2 neurinomas are outside the spinal canal. Gasserian ganglion is outside the skull, essentially in the interdural compartment. The tumors of C2 neurinomas are within the dura, interdural. In the year 2008, we said that this part of the tumor is intradural. In 2003, we said that this part of the trigeminal neuronoma is intradural. But later we said that both these components are interdural. You see, this is C2 neuronoma and this is trigeminal schwannoma. Both have similar, they are interdural in location. This is C2 neuronoma, this is trigeminal neuronoma. Both are interdural in location. You work within the dura and you can remove these tumors without laminectomy. You work within the dura and you can remove these tumors without craniotomy. We describe this for the first time in literature. Removal of such tumors without laminectomy or any bone work, and removal of these tumors without craniotomy, essentially based on the understanding of dura. So NF2 are bilateral, even bilateral C2 neurinoma and bilateral trigeminal neurinoma. Ipe, my dear Ipe, can you tell me how much time I have so that I can actually continue for as long as you want? Can you tell me how much time I have?
Maybe the next 5 minutes.
5 minutes? Okay, let me show you quickly. So this is C2 neurinoma, you see, with extraspinal component. This is trigeminal neurinoma with extracranial component. Similar philosophy of dura, we have said about 7-nerve neurinoma. 7-nerve tumor is a difficult skull-based tumor, but if you have the concept that these are within the dura, not only the middle fossa, even the posterior fossa component is within the dura. And these tumors arise in the geniculate ganglion and they remain within the dura. If you have this concept, and if you think that this is not the tumor capsule and you try to save the course of the 7th nerve, there is a possibility of preserving the function of the 7th nerve. Regarding trigeminal neurinoma, we described for larger tumors in 1996, we described basal extension of subtemporal middle fossa approach. My incision was like this. You see the incision going behind. And the other beautiful thing is the temporalis muscle was rotated anteriorly. You see, we do zygomatic osteotomy because the temporalis muscle obstructs your vision. So when we rotate it anteriorly, the temporalis muscle does not interfere in your middle fossa approach. In that paper, we also described the resection of the root of the zygomatic bone, the roof of the condyle, the roof of the external ear canal, and partial mastoidectomy. You see, partial mastoidectomy. Subtemporal craniotomy and mastoidectomy was incorporated for the first time in the literature. In 1996, we described this article. And we used this approach for trigeminal neurinomas. So this was after my exposure extradural, and then open the dura and remove the tumor trigeminal neurinoma. And if it is going in the posterior cranial fossa, then my strategy is to come intradural, open the tentorium, and then cut the tentorium and expose both the middle and posterior cranial fossa components at the same time. So this is the exposure, removal of root of zygoma, roof of condyle, roof of external ear canal. I don't do this kind of exposure now after my continued experience in trigeminal neurinoma. I do a very small craniotomy over the roof of the zygoma here in the squamous part of the temporal bone. But this was the exposure that we described, and this was my experience in long time ago. And you can see the condyle and external ear canal and mastoidectomy. Now we do just splitting of the temporalis muscle and do a small craniotomy over in the base of the skull, and then work within extradural compartment and then interdural compartment and remove these tumors. More importantly, lateral position, lumbar puncture are very important component of this lateral approach. So this majority of these tumors, they are not very firm tumors. They are soft and necrotic tumors. And on several occasions, they are cystic tumors. So you come from here open and you can remove this tumor in very quick time. Maybe in half an hour, you can remove this tumor. More importantly, when you remove this tumor, you have to see that you don't coagulate too much, because if you coagulate too much, then there is a possibility of damaging of the fifth nerve fibers, the fifth nerve fiber. So you cannot just damage the V1 division, which is very critical division of the fifth nerve. If you damage, you create corneal ulceration and opacities, which of course will not be tolerated. This is another tumor. You come in extradural, interdural, debulk the tumor, debulk the tumor, debulk the tumor in quick time. Do not coagulate, do not coagulate. Carotid arteries away from the dura, separated by the dura. The venous complex is separated by the tumor, by the dura. Debulk, debulk, debulk. Do not sacrifice the trigeminal nerve, which are coursing through on the dome of the tumor. Essentially, this nerve arises from a fibril of the trigeminal nerve, and then it enlarges. Rest of the cranial nerves are saved up on the dome of the tumor, and you have to save these cranial nerves. Essentially, learn the art of demolishing the tumor, learn the art of breaking the tumor, learn the art of removing the tumor without coagulation, and that may be the trick of the trade in these tumors. So this is another tumor, pre-op, post-op, removed. For tumors which are essentially anterior, I come from this direction, from here. Tumors which are going in the middle fossa, I come from more lateral in the subtemporal area. So this tumor, you see how it has been removed long time ago, maybe 25 years ago, I removed this tumor. This is another giant dumbbell-shaped trigeminal neurinoma, which has been removed radically. So as I mentioned, my experience is nearing or maybe more than 300 cases of these trigeminal, which is by far the largest experience in the world on this subject. And because of this, due to my hospital, KEM Hospital, which is a public institution, huge number of cases has given me this strength and power to operate such tumors in quick time. Maybe if I operate this particular tumor in more than 45 minutes, I will be quite depressed or disappointed. So this is another tumor which will take longer time because this is going in the posterior fossa. I'll have to cut the tentorium. Maybe I'll have to cut the superior petrosal sinus. Or sometimes I work over the superior petrosal sinus and preserve the superior petrosal sinus. There's a big distinct possibility. So this is one tumor, pre-op, post-op, pre-op and post-op. Even when there is a small nubbin like this part is also within the dura, and that you must remember that this is not going inside the cavernous sinus or having some strange kind of relationship. So this tumor can be removed. Cystic tumors are and necrotic, easier to remove, but you have to remove it radically and completely. These tumors are more likely to recur. So that is another negative part of these tumors. So this is pre-op and post-op. This kind of multiple cystic tumor, easier to remove, soft, necrotic, don't have to keep on coagulating in these tumors, but these tumors are more likely to recur. So you're seeing several tumors which have been removed and removed beautifully. This is a large cystic tumor which had been operated earlier, and then I removed, and then this tumor recurred. This is a recurrence of the same tumor, and then we reoperated this tumor. So this is another recurrence of cystic tumor. So cystic and necrotic tumors are easier to operate, but can be, there can be a possibility of recurrence more often. Extracranial extension, also there is dural presence, which we must remember. And you work within the dural confines. You can remove these tumors within the dura, and we remove this by cranial route, not by, you can of course remove this by nasal route, also by infratemporal fossa route, but we describe reverse skull-based approach for these tumors. Like remove from the cranium, go down. So we had reported this 28 cases long time ago. Now we have several more cases of extracranial extension. This is another tumor with extracranial extension. This is multi-compartmental tumor, posterior fossa, middle fossa, extracranial tumor. And we recently published this, that even when the tumor recurs, usually the recurrence is apoplectic. They can be bleeding within the tumor. And the recurrence is also interdural in location. So this is what we recently published. So thank you very much, my dear friends. And I hope you enjoy this session in Krishna Medical Institute in Karad. And my best wishes to all of you, the young team of neurosurgeon led by my dear Ike. Thank you, Ike.